Good evening, ladies and gentlemen, and welcome to tonight's JCN Facebook Live. Thank you for joining us. And based on the fact that this is our last one of the year and it's the 1st of December, a very, very Merry Christmas. Tonight's event is called Easing Winter and COVID Pressures, Making the Self-Care Switch for Venous Leg Ulcer Management. And our awesome speaker tonight is Joy Tickle. Good evening, Joy.
Hi, Ed. Hi, everyone.
Merry Christmas.
Oh, yeah. Merry Christmas. 1st of December. I always start to get excited round about now.
So I was thinking earlier that Joy was the first ever presenter we ever had on a JCN Facebook Live over 3 years ago. It was utterly terrifying. I'm not sure I'm any less nervous now than I was then, but we've now had hundreds of thousands of delegates and viewers over the last 3 years. So Joy, thank you for being the first. And thank you for presenting tonight.
It's my pleasure.
Ladies and gentlemen, as you can see, Joy is doing tonight's event from her home. So if we have any technology problems, please bear with us. And I promise you we'll endeavour to get them sorted as soon as possible. Tonight's event is available on Facebook Live forever for free. We will also put it on our website, jcn.co.uk, where you can watch it for free, but also download the slides. We get loads of questions around slides, so you can go to the JCN website and download it. The link for your certificate of attendance will appear on the screen and in the comment bar towards the end of tonight's event, and that will count towards your revalidation portfolio. Guys, please get involved, make comments, ask questions. The more involved you are, the better the event is, and we'll endeavour to answer as many of those questions at the end of tonight's event. Before we start, a massive thank you to our partners tonight, who are L&R. L&R have supported our business since we started. L&R are utterly driven around independent education, not just for the healthcare professional, but almost uniquely for the patient. They have been driven by patient education, patient thought, consultation when it comes to product design. I know, having met and spent a lot of time with their team, how much patients mean to them. So them supporting tonight means the world. Enjoy. We'll talk about squeeze in a second, but it's so driven by the patient. I'm really hoping that you and your patients will engage with it. So without further ado, it gives me great pleasure to introduce tonight's speaker. Over to you, Joy.
Thank you, Ed. Good evening, everyone. It's my absolute pleasure to be presenting and discussing with you this evening around easing winter pressures, COVID pressures, and embracing and supporting self-care systems for our patients with venous leg ulcers. And supported self-care is something for many years I've felt very passionate about. So it was an absolute privilege to be asked to talk around this subject with you this evening. I know every day, don't we? We see in the press, on the news, in fact, I was watching the news today, and there's further publications and news about the pressures, not just the NHS are facing, but all care providers. We are under enormous pressures. We're still hearing about insurmountable challenges that we're going to face, both due to winter pressures, as we're aware, and due to COVID-related pressures. And that's not just new COVID cases, but it's managing and looking after the patients who are still recovering from COVID, meeting their physical and mental health care needs. So additional pressures there as well. And I myself work within the NHS. I have done for 38 years. And already myself and my colleagues where I work, we're seeing the evidence of not just the COVID pressures, but winter pressures. But I think, when I look back, I feel that maybe those pressures are not just winter. I think we've been under those pressures for at least the last 18 months, haven't we? If not longer. And I'm sure you can agree with me on that. But in addition to that now, we have to address the backlog of service delivery, due to the demands placed by COVID-19. Essential diagnostics and treatments for our patients had to stop. But now we have the backlog challenge of reinstating those crucial assessments and crucial treatments. So that's additional pressures upon us. Patients are requiring discharge into community services sooner rather than later. but with no additional resources. And I recently have seen patients in acute hospital beds who are medically fit for discharge, who unfortunately cannot be discharged because a lack of health or social care packages. You know, and this is critical, not just now, but moving forward. We've seen staff redeployed into different care settings or working temporarily in teams. And these staff who've had no exposure to wound care or wound management. And I was very much involved and still am in quickly training these staff and giving them the tools essential to help them to implement wound dressings and make decisions. And what's benefited me there is the use of really good evidence-based clinical pathways, which has helped to support the staff in making those decisions. And I don't think that redeployment or transfer of staff from different areas is actually gone away. I think we may see that still happening due to unsurmountable pressures. And what I'm sure all of you are agreeing with, no matter where you work, whether it's in your community, in your care homes, on your wards, staff are reporting unmanageable caseloads and significant unmanageable caseloads and under that enormous pressure. And even prior to the pandemic, you know, the NHS was facing a crisis way before the pandemic, particularly in the community workforce perspective, but fast forward to today, and this is rapidly escalating. Projections by the King's Fund estimate that the NHS staff shortage will reach 250,000, if not more, by 2030. So that's within the next 9 years. And it's estimated that internationally, there'll be over 50 million more people over the age of 65 with a wound. So that workforce challenge is enormous, and the fantastic work done by Green this year, addressing workforce challenges. You know, staff were reporting, I'm seeing 20 patients, I have 20 patient visits a day, it's unmanageable. You know, they're suffering, their well-being, physical and mental well-being is suffering, and they don't feel supported. Experienced staff, and I've seen this happen such a lot over the last 2 years, experienced staff are leaving. We're not replacing them. And again, that not only impacts the care we deliver, it impacts the team that you're working within. And, you know, it's a massive, massive consideration to make. And, you know, you can see on your screen, on top of the pressures, we have the challenge of the burden of wounds. And I'm sure all of you are familiar and have heard on previous Facebook Lives and other platforms about Julian Gestertel's work around the burden of wounds. And his study, you know, his first study in 2012, 2013, his second study, 17, 18, is given us a lot of valuable information, not just about prevalence of wounds, but health outcomes, healthcare resources, and of course the cost. And what you can see is that over 1 million patients are living with a leg ulcer. That, you know, that equates to 2% of the population. And what you found recently is that there's been a 71% increase in the number of wounds that we're caring for. 71%. That's a massive increase. But have we seen a massive increase in resources? No, we haven't. And we are also facing those additional pressures, those additional challenges I've just mentioned to you. And what I will say to you is that leg ulcers still continue to be the most prevalent wound in the UK. Yet we have all this evidence about best practice for leg ulcer management, venous leg ulcer management, but it's still the most prevalent wound type. Why is that? I'll ask you, how many patients on your caseload do you have with a lower limb condition? And how many of those patients have you actually treated in the past and they've reoccurred? And I'm sure some of you can even name quite a few of them in person. And I've seen that myself in practice. And in addition, with the burden of wound care escalating, you know, the national wound care strategies show that over 50% of community nursing time is spent caring for patients with wounds. Now, the community nursing teams are all already stretched because they're caring for the more complex patients now. But we're seeing the number of community nurses declining. And we're also seeing nursing and social care staff leaving. So again, that's going to have an escalation on the problems we're facing. and cost of wound care, over 3.1 billion annual estimated cost, and that's just caring for patients with leg ulcers. That does not cover all wound types. So if we could just free up just a portion, 10%, 15% of that time spent on wound care, it would free our time to spend with more complex patients, wouldn't it, and address those challenges we're facing. And the burden of wounds continues to rise. Who would have thought that the management of wounds sits sixth in the burden of illness table, above managing obesity and above the costs similar to smoking and alcohol-related conditions combined? It's a massive, massive burden of illness. But I'll ask you, what is the cost? What is the cost in terms of pressures on you? And I see that working every day in practice with the team that I work with. Enormous pressures on our time and on your time. Enormous pressures on the resources available to us. And I'm a big believer in having the available tools and resources. We can't, implement evidence-based practice without those tools and those resources. But what's the cost in terms of pressure on your well-being? And I think that goes without saying, doesn't it? Your physical well-being and certainly your mental well-being. But I'll ask you, what is the cost in terms of pressures to your patients and the families when they're living with a wound and a wound that is not healing? Massive cost, isn't it, to their quality of life? So what can we do? What can be done? I want to say, let's start. Let's address now some of the key solutions and put them into action before there's any additional pressures that we're going to face. Let's get ahead of the potential snowstorm that we may face. And I think that's what we can do, and we'll talk about tonight. So how can we get ahead? How can we move forward? How can we free up nursing time? How can we reduce unnecessary contact with our patient? Now, that doesn't mean we don't want to see our patients and we don't want to have contact with our patients. Of course we do, but we can help to release some of that time. So what I want to talk about is start by assessing your caseload. Just look at your caseload. I know we say we haven't got time, so whether that's in your ward, in your care home, your practice, or your district nursing team, start with your caseload, okay? And use an evidence-based leg ulcer pathway like the one you see on the screen that talks about supported self-care. And let's try and unpick or ascertain the patients who can switch to self-care solutions or self-care compression systems. It's simple, and this is what I have used in practice and continue to use in practice. So what we're doing with the pathway is we're assessing the patient's suitability for supported self-care, we're assessing the wound, and we're assessing the limb. And that pathway helps you to make those clinical decisions quite easily and quite simply without having an in-depth knowledge and skills of leg ulcer management. It's supporting you to make those decisions. So let's identify those patients, switch them over to a compression system such as a Hosiery kit or a rack system that can encourage supported self-care and help them to have full therapeutic compression, but without the need for bandaging. So that will release time. That will free up some of your valuable time. And those sorts of patients we're looking at are those with controlled wound exudate and minimal limb distortion. So, we can encourage supported self-care for those patients. What I want to say and emphasize here that I totally, professionally and utterly respect that we still require compression bandaging. The compression bandage is a key component here of the leg ulcer pathway, and it's essential for those patients that require it. But what I'm trying to say is those patients who do not require compression bandaging and could be receive compression through a different system, let's switch it over and let's free up a little bit of your time, your valuable time, and also give our patients that independence. So if you look at the pathway and focus on the part of the pathway where it talks about self-care compression systems, it will talk you through looking at your patient. As I've just said, exudate, is it controlled? Exudate, minimal limb distortion. And I'll ask you, for those patients now, just think of a patient who's got minimal exudate, limb distortion is minimal. Are they in a self-care compression system? If you say yes, fantastic. If you say no, it's not a negative, just rethink and revisit those patients, okay? Self-care, can be, I think we always think that we're going to abandon our patients. And I've heard staff say, do you discharge the patient when they're self-care? Absolutely not. We need to support the patient. It's supported self-care. And that self-care can be delivered by the patient themselves, a family member, a carer, where we're giving them simple teaching and advice and tools to support them to undertake that care. But what I want to also talk about is self-care compression systems, such as your hosiery kits or your wrap systems. You may have a patient who can't physically, for whatever reason, apply that system. But does it mean that you don't use them then in practice? Because certainly if you can use those for the patients where they're suitable, how much quicker is that to apply than a bandage? How much cosmetically and more comfortable is that for your patient? Your stretch teams, you can now expand into a wider skill mix. So the wider team can be involved in delivering that compression therapy. It doesn't have to be an RGN. So again, think about that for all of your patients as well, not just the supported self-care patients. And as I've said, this is a prime example of one of my patients that did require compression bandaging. On presentation, the patient had a large wound, heavily exuding wound, limb distortion and edema. And following the pathway, we made that clinical decision with the patient that she required compression bandage therapy. However, moving along the healing continuum, exudate levels became reduced and manageable. Limb distortion was no longer a problem. Limb shape improved. And guess what we did? We didn't remain in bandages. Again, we used the pathway to help us to talk with her about a solution, a self-care supported solution. And she was then put into 2-layer hosiery kit. You can still see the dramatic improvement in her limb. You can actually see on the screen all of the emollient on her skin as well, which is fantastic because this was something she could do by just rolling the hosiery kit down and applying emollient. Her skin felt more comfortable. She felt engaged in her care. And isn't that what it's about? It's the patient's limb. But what that also meant is it freed up the clinician's time. But the lady was supported all the way along with this, with her treatment and the system. So the pathways and legal pathways, I'm sure you have. If you haven't, please don't reinvent the wheel. There's some fantastic examples of evidence-based pathways. But any evidence has to, we have to have really good evidence, don't we, to support our changes in practice. And this is the evidence I used when I was looking at the self-care options and the use of hosiery kits. And it was the Venous 4 study back in 2014. That's some years ago now. But it was a really good study that identified that not only do self-care compression systems, such as the hosiery kits, support the patients and supported freeing up of some of your time, they were also clinically effective and cost effective and did reduce dramatically the reoccurrence of ulcers. And that is the evidence on your screen. You can see, and I'd recommend any of you to look at that. And that gave me the evidence to go to my organization to make changes to the pathway and to introduce systems that were originally not available to us, but to put that argument forward for those resources of the hosiery kits. And what did that mean in practice? I'll share that with you in a little while. Just for those of you who are already familiar, I know many of you are very familiar with the leg ulcer hosiery kit, but I'm just going to explain to those of you who are less familiar of what it consists of. You can see on your screen, it consists of a silky liner that is first applied. Now that liner does give compression therapy. It's given 10 millimeters of pressure, but what the advantage there is, it's silky, feels comfortable on the skin, and it can hold the dressing in place. The second sock is applied over, and it's easily fitted because it slides over the top of the silky liner. Now this then also gives therapeutic compression. So the two combined will give 40 millimeters of pressure, which we know is optimizing venous leg ulcer return, return and assisting venous leg ulcers to heal. So lots of advantages there as well for the kits, because, you know, you don't need advanced level of knowledge and skills to apply them. It's easily taught how to apply them. And what I will also say is our patients reported they were a lot more comfortable to wear, and certainly staff reported if they were assisting the patients in applying them, it was so much more quicker to apply. And again, one area that I found that it was really advantageous in is stopping a break in treatment. So I'll give you an example. Recently, a patient was admitted to an acute ward in a compression bandage system. And unfortunately, the staff on the ward, which was no fault of their own, didn't know how to apply compression bandaging. So that compression bandaging was stopped. So really, if you think about it, we're stopping a treatment. We are actually stopping a therapeutic treatment for our patients' wounds and for their venous return or for their edema. So potentially we could be harming that patient if that wound should deteriorate or that limb deteriorate. And I know we don't deliberately set out to harm our patients, but we are actually at risk of harming them because we're stopping the treatment. And if that patient was in a self-care solution, such as the hosiery kits or the wraps, surely then that treatment can continue, can't it? It's so much easier to continue that treatment and stop a break in their therapy. So in addition, I'm going to explain to you what the compression wrap system is. As you can see on the screen, it's an adjustable compression wrap. It's got Velcro fastenings, very easy to apply and to adjust. It delivers full therapeutic compression for the treatment of leg ulceration and edema, and it really can empower our patients or their family or carers to support that self-care. Now, I myself use wrap systems in my practice, and I do recognise and must add there is an evidence gap at the moment with regards to them. However, what I will say is look out, because currently there's a further RCT study underway, the venous 6. And what the venous 6 study is doing is comparing 3 different compression systems to treat venous leg ulcers. So they're looking at the compression wraps, they're looking at the 2-layer hosiery kits again and 4-layer bandages and 2-layer compression bandage systems. So I'm really looking forward to looking at the results and evidence from that study when it's produced as well. So I'm sure you've heard on various platforms, certainly on this Facebook Live platforms, we've talked a lot over the last 2 years about self-care, haven't we? And we've had some fantastic presentations about what self-care is and how we can support that. And I'd encourage you to go back over and watch those presentations again. We know self-care is not a new concept. It's been around for many years, particularly in the management of chronic diseases, you know, such as respiratory medicine and diabetes. For self-care for wound care is fairly new. It does make people a little bit nervous, but it shouldn't do, because we have some fantastic self-care tools, information, resources, videos that we can support us as clinicians in implementing self-care, but most importantly support our patients and families and carers. So, you know, there's some fantastic, and I'm going to share some of those tools with you later, that can really help you to engage with supported self-care for your patients. And I think one of the big areas of self-care, what I found when I've supported our patients with this, is we're giving the patient confidence, aren't we? We're gaining confidence, but the patient's gaining confidence. They're gaining confidence to know that they're allowed to look after their skin or their limb. It is their limb. And I'll give you an example of this, and particularly in venous leg ulcers. How many of you actually start the conversation with your patient that they have a disease? You know, like you would if they had diabetes, they have chronic, you know, they have venous disease. And if we're not informing them that they have a disease and they have that disease for life, how can we encourage them to take ownership of that condition? You know, so I always, because a lot of patients feel that the leg ulcer is the cause. And when you've healed the leg ulcer, they don't need compression anymore. They don't need to do skincare. But that's not their fault. That's because we haven't explained that they have a disease. And I found that supported self-care has allowed me more time to engage with that conversation around it's their disease. And they've been so more receptive then to think about that long-term compression. It's given them the confidence as well. What I've also found is it's opened up a massive dialogue with our patients. For me, it's putting the patient at the centre and asking them, what are your objectives? So you jointly setting those objectives together, that to me is what wound care should be about. So the patients are feeling part of your team, the patients are feeling listened to, and you're setting out those realistic objectives with them around not just self-care, but their wound care as well. And I'd like to just share with you, just go back a little bit with how, due to our own local winter pressures in my previous organisations, we successfully did achieve that but only by utilising the evidence that was available. So we did implement the leg ulcer pathway. Our staff within the community, this is a few years ago now, were facing those winter pressures. There was no COVID at the time, but patients were being discharged sooner from the hospitals, earlier discharges with no increase in resources, which we are still seeing today. Staff were reporting unmanageable caseloads, and one practice in particular, very honest practice nurse phoned me up and said, Joy, we haven't got capacity or time to be applying compression bandages to our patients with leg ulcers. And she said, I don't know what we can do. I don't know what can give. So I visited the practice, and between us, we looked at the cohort of patients with venous leg ulcers, and using the pathway and how it helps you to make those clinical decisions, what we wanted to do was switch any patients we could into those supported self-care solutions, which for us at the time was the Hosiery kits. And we chose 15 patients, and those 15 patients, with consent, of course, we educated them on general skincare, simple wound dressings, and applying and taking off the Hosiery kits safely. If the patients couldn't do it, we supported the family members or the carers. We gave them the red flags to look out for any signs of infection or limb shape changes or wound increase in size, and who to seek advice from immediately. And what we found also then, of course, is the patients required less appointments. But it does not mean we discharged the patient. We supported the patients. The patients continued. Some patients attended the practice once a week, some patients fortnightly, and in between, the patients were supported by a phone call from the practice nurse. But even the patients who attended the practice, you can see how much more quickly it was to apply the compression therapy. These were the results. The appointments, the total number of appointments went from 43 a week to 23. That's to 26, sorry. That's a massive reduction, isn't it? Not only were the results clinically effective, so the wounds were healing, the skin was improving, we had a reduction in costs. So it was clinically effective and cost effective. So average over a 12-week period, each patient's treatment went from £656 down to £150. And it's important that we do consider these factors as well. Clinicians report a reduced number of clinic appointments or visits out into the community. They were easy to apply. And this is what the patients said to us. They actually felt more comfortable in the Hosiery kits. They cosmetically found it more pleasing. And they found that they could enable to support them with their own self-care. So they weren't dependent on appointment times, or if the weather at the time, you know, we had some inclement weather, that didn't restrict them getting their treatments anyway. But it made me reflect when I saw these really positive results. The staff were happy, the patients are happy. And it made me question, why did we wait until winter pressures or any pressures before we implemented that evidence base around supported self-care? I don't know. Why did we wait? So that made us not wait. We just implemented it across the county in all sorts of care settings. So we ensured that that care was equitable to all of our patients. And we didn't wait. It didn't matter if we were not facing pressures or not. It was just good standard care, evidence-based care that we implemented. And I've changed organisations now. And the organisation that I work in, this is standard practice for our patients. And why wouldn't it be? It's so transferable, isn't it? And I want to share with you one of my patients' self-care journeys. Don't take my word for it. Take one of my patients' words for it. This is Brian. Brian's a 62-year-old gentleman. He's married. He's a HGV driver. He's had a long history of venous disease and recurrent ulceration. So, you know, despite goodwill, he'd go into bandaging, the ulcer would heal, but then he'd reoccur. He frequently lost time from work because of appointment times. He was not paid when he could not attend work. He had recurrent infections and again wasn't paid if he was off work, and so loss of income. He also said to me he felt obviously embarrassed with the stigma of having a leg ulcer, and you can imagine working if people were aware you had a leg ulcer. He said he used to get a lot of not name calling, but sort of comments made about the fact he had a leg ulcer. So it caused him a lot of anxiety and stress and fear, and impacted negatively on his quality of life. So, you know, upon assessment, he'd been attending the practice nurse, and the practice nurse saw, you know, how supported self-care could work. She had the tools available. She used the pathway, and she thought, let's switch this gentleman out of these bandages then. He got minimal exudates. He had got small wounds, and his limb distortion, he had no limb distortion. So she taught him about skincare, washing, simple dressings. She gave him links and leaflets and videos online that he could use as resources, and supported him by still continuing to see him at the practice on a fortnightly basis. This was the gentleman in 4 weeks, and you can see the massive improvement to him, not just to his limb, the wounds healed, his skincare was improved. Now, his skincare was improved because he could apply emollients more frequently. He couldn't do that when he was in bandaging, and I do totally respect that. The practice nurse supported him all the way through and monitored, you know, his condition, and again, monitored his quality of life. He was just particularly over the moon because he said, you know, because he looked like he was wearing socks, nobody questioned him. He could wear his footwear for work. He could wear, you know, nobody actually said, oh, have you got a leg ulcer, because his leg was in bandages. He felt more confident. He could see the skin improving in the wound dramatically. So that eased his fear and his anxiety and his stress levels. What was interesting here, and we gave him some fantastic leaflets and support tools, but what was interesting here is he actually said to the practice nurse, his legs healed, and the practice nurse talked about his disease, his venous disease, and he totally understood that he needed to wear that compression now for life and to care for his skin and to care for his limb, and he absolutely embraced it. He understood why he needed to continue to wear compression hosiery. So I will guarantee you, I can't tell you yet, maybe next year I will, that he will continue to not reoccur because he's taken that ownership. And he even made health style changes because he was doing a lot of reading, and he got the support literature to make some changes in his life per se. You know, he started eating more healthily, he started walking more and exercising more. So, you know, again, that engagement with your patient can have a massive impact on their life. So how can we support you? How can we support you to put this into your practice if you haven't already done so? Okay, we have lots of tools. Everything I've spoken about this evening is available. Eleanor have produced a really fantastic winter pressures module, which can support you to assess your caseloads, make the switch to self-care solutions. It's got lots of tools that you can use as a clinician to help you make those decisions and to make those clinical decisions as well. It's got tools for your patients, okay, and that's important because it's about working as a team with your patient and with you as well. So I would encourage you to visit the website. Don't reinvent the wheel. I'm a big believer in that. There are some fantastic resources there for you to use. You know, use them and utilize them. But equally, don't just think of this as a solution, okay, when you face work pressures. This is evidence-based solutions for your patients now. This, to me, should be implemented from day one, from first assessment, you know, from first contact with that patient. You know, don't wait for winter pressures or any pressures. This is gold standard treatment for your patients. And I want to introduce you to, I found this absolutely fascinating, is the club squeezing. And some of you may be already aware of this. And what I love about this is that it actually empowers the patient to manage their leg health. And I love that because it talks about leg health as opposed to healing the wound or keeping the wound healed. It actually starts with preventing the wound in the first place and keeping the limb healthy and preventing problems. Yes, it will also support the patient about their leg ulcers if they do develop an ulcer as well. And it's not just about the leg health, it talks about general health condition as well and improving their health condition and how they can do that. It's got fantastic resources. As I've said, you've got support for you in the resource packs, you've got support for the patients where they've got, you know, up-to-date information, easy to use healthy living booklet, and it's got really good hints and tips, and I love simple hints and tips for clinicians and for patients as well. So you all might be looking at that screen and think to yourself, oh, well, why is there a picture of Johnny Vegas on the screen? Johnny Vegas is a proud supporter of the Squeeze In campaign. He's passionate about breaking the stigma around leg ulcers, which I am too. And he sees the value in self-care in preventing escalation, you know, so it's about that prevention, as well as helping to empower people. And this is all based, his passion is based on his own experience of helping his own father to manage his venous leg ulcers. So he has a wealth of understanding and experience in helping his own father. And I would like now to share his video with you.
I think in an older generation, it's more the debilitating factor is the shame. Do you know what I mean? That if it's not cared for, if it's not done, to not be as mobile. I think the pressure on younger people, if you look now on social media, to correct themselves, to be perfect. So the first time you see something on your leg and you go, what's that? You know what I mean? I'm less than perfect. We're all less than perfect. Be it on the outside or the inside. If it's an issue with you, find help. I don't think there's any part of us that needs to be hidden away, emotionally or physically.
And I'd encourage you to actually go on the L&R website, join the Squeeze In campaign, because that's just a snippet. That is just a small snippet of not just Johnny Vegas's thoughts, but also, you know, how there is that stigma and how there shouldn't be that stigma associated with any patient with a wound, but particularly with leg ulcers. And, you know, I think it's so important that we start to recognise that even more so now. And, you know, you've heard and seen this evening, hopefully, how supported self-care can be successfully achieved. But as long as the patient is at the centre of their care and is part of your team, I'd ask you now, how many patients do you have on your caseload that you could put into a self-care compression system? And I'd love it if you would take a few minutes or just a few seconds even to just submit your answers in the comment box, because it's interesting to see how many patients, you know, it's hard just sitting at home at the moment or at work and trying to work that one out. But I'm sure there's quite a few of you with patients that could be put into a self-care compression system. And I think now more than ever, there's a need for patients to engage and adopt a self-care management routine in order to successfully manage their venous disease. So before the ulceration, manage their venous disease, manage their limb condition, you know, or if it's edema or any other conditions. I mean, the potential benefits for your patients, their families, their quality of life, and you as a busy clinician are substantial. And I'll just probably end my final slide by asking you to just think tomorrow or whenever you're next back at work, just choose 2 patients out of your whole caseload or on your ward or in your care home, and just choose 2 patients where the switch to self-care options can be made. Implement it and just see what a massive difference it will make to their lives and your busy caseloads in your lives. And I'm now going to hand over to Ed for our live Q and answer session. And I hope you've all been very kind to me and not given me really, really difficult questions. Ed.
Joy, these aren't my questions, and there's lots of them.
Oh,
Thank you. Thank you so much. I know we were both giggling before, that we were both quite nervous, but you absolutely nailed that. Just a really important presentation, as well as brilliantly delivered. So thank you so much. Do you mind if we crack on with the questions?
No, crack on, crack
on. So question 1, Joy, how can we support patients to move to self-care options?
I'd love to speak for another 40 minutes, but I don't think I can. I think it's always a worry, and I think that's a fantastic question, because when you first start out, and I remember when I first chose the patient for supported self-care, and I thought, oh my God, my first thought was, what if I get it wrong? You're not going to get it wrong, because you're going to, you won't get it wrong. If it's not right for the patient, it won't be right. So you won't get it wrong. But I very much needed tools to help me, because it's all well and good talking with your patient, but you know yourself, even this evening, how much information you retain, isn't it? So I used very much the tools, patient leaflets, patient videos, use their patient language, just your patient better than anybody. So use the terminology, use the language they understand, but use the tools, because you've got to leave them with something to support them, or even just to think about, because you can't expect your patient straight away to make that decision. Some patients take a few days or even a week or so to even think about supported self-care. I think the main thing is, though, is really reassuring them that you're not going to abandon them, that you're not going to discharge them, that they're still part of your team, they're still on your caseload, they're still in your care home, because I think that's the fear for most patients, particularly community patients, where they rely on the nurse to visit, or they like to see the practice nurse because they're reassured they're getting the right treatment. So I think it's building that confidence that they will be getting the right treatment as well, that that treatment isn't substandard because they're involved in it, or it's a different system. Brilliant. So hopefully it's answered that.
It does, thank you. And this question leads on from that, actually. What tools are there to support patient application of self-care compression systems?
Lots. I mean, we've already mentioned Eleanor's platform. Please visit it. I know JCN, you've got lots of really good educational tools and self-care solution tools as well. So, there's lots out there, but what I would say is use what's right for you and use what's right for your patient. Do not reinvent the wheel, guys. We use these systems, we use these tools, and they work extremely well. So there is lots out there, but it's just a matter of just, spending a little bit of time looking at the tools. Go on the websites that we will be sharing with you at the end of tonight's session as well. Ask your colleagues. I'm part of a tissue viability group. We're always asking each other in this closed group, what do you do for this? Have you got a self-care, I don't know, patient passport, and we share it. So please just share amongst your colleagues as well, because you'd be surprised how somebody just down the road from you may already be doing this, and you can learn from each other and support each other, because it's about supporting you as well, not just within your own team, other colleagues in other areas. And it works extremely well in care homes as well. Residential care homes are engaging with it now and supporting patients with the support of the DN. So it's fantastic.
Brilliant, thank you, Joy. And you're right, I'm not just because they're partnering tonight, but the LNR site has got so much education there and has done for years, actually.
And it's very patient focused as well, which is what you mentioned earlier. It's very much the patient at the centre, which is what it should be about.
Brilliant, thank you. So next question from Karen. Thank you, Karen. How often do you prescribe the wraps? Is it every 6 months?
Oh gosh, now she's asking me a technical question now. It is normally 6 monthly, and if I am wrong, please, Eleanor, put a question up, but it's normally 6 monthly. What I will say to you is, with your patients, there's always, like you would with hosiery, like you would with bandaging, you keep an eye on the patient's limb size, and if anything changes, so keep resizing now and again if anything changes. But normally, because the wraps are adjustable, it's fantastic for that. So if we did have a period where it was a little bit more edema, the patient can self-adjust that. So that's why it's fantastic for that, but it is normally 6 monthly.
Fantastic. Question 4 from Maureen. Thank you, Maureen. On which patients would you use a leg ulcer hosiery kit and which patients would use a wrap system?
Yeah. Well, hopefully the image I showed you as well. I know one was bandaging and one was the hosiery kits. With the hosiery, I would very much look at minimal limb distortion, exudate contained, that principle. With the wrap, if I had got edema and a little bit more limb swelling, I would then use the wrap as opposed to the hosiery. But to be honest, with hosiery, if there is a little bit of edema, then I would use the European hosiery kits, because they're for those limbs with edema, and those without edema, the British standard hosiery kits. So I don't think it's black and white, Ed. I don't think it should be black and white either. There's a guide, there's a clinical guide, you know, amount of exudate, amount of edema. But I have had some patients who I've thought actually they required a bandage. Now, I'm sole believer in compression bandaging, but this one patient absolutely wouldn't have compression bandaging. And I didn't think it would be as successful, but we did actually then, with support, apply a wrap system. We were getting full therapeutic compression. It did take a bit longer than if we could have put that patient into compression bandage for a few weeks first and then changed him into the other system, but it worked. So I think you've got to know your patient, know the wound, know the limb. And you'll make those decisions, you will. You know, sometimes I've swapped, I've, you know, sort of put one system in and it thought, you know, it maybe isn't right for the patient, and I have swapped, but very rarely. I think you the more experience you get with them as well, the more confident you'll grow. But use the companies to support you with that clinical decision. That's what they're there for. You know, it's their products, they've done the research. So don't be afraid to ask for support and advice from the company as well, because they can offer fantastic support and advice.
Yeah, but so much is confidence, both from the healthcare professional point of view and from the patient point of view. And you see so many people, I hear so many people scared of compression, scared of talking to the patients about compression. And if we can change that, so much can change, and so many legs will come back.
And if we're scared, Ed, then how are the patients going to feel? Do you know what I mean? If we're a little bit scared and a little bit lacking confidence, you know, I can understand why then we're a little bit worried about how we're going to educate our patients. But, you know, you don't have to necessarily do the education. The education's done for you with these fantastic tools. You just have to support the patient through it.
Correct. Question 5 from Christine. And there's lots of exclamation marks in this, so I'm tempted to shout it out, but I won't. Being ward-based, I have never come across wrap systems. How can I get these implemented? These would be invaluable in areas where nurses aren't trained in compression therapy. We do seek TVN advice, but they have never suggested these systems.
Fantastic question, Christine. And you know what? I'm just so pleased that you're now saying we want that. You know what I mean? You're saying, why haven't we got this evidence in our practice? And I'm going to challenge that. And I want it in my ward situation. And I want to carry on compression for our patients, which is fantastic. If you haven't got, use the evidence and the pathways, you know. So if you have to challenge and say, right, to the TVN or to your procurement or whoever you get your compression from, the evidence is there. It's going to, for me, continue therapy for a patient, not break the therapy and not cause the patient potential harm. So start with that one. And you can get them, you can order them through your supply systems or on, obviously you don't do prescriptions, you're on the ward, or you can actually request, you know, the patient can request them through the GP. But I'd start with, have a chat with your TVN though, you know, have a little chat with her. It may be because, as I've said, we're waiting for some of the evidence around the wrap systems, but I have used them, you know, clinically for a good few years, and they are, you know, clinically effective. So some may be a little bit reluctant to use the wraps till that evidence comes out from the, you know, the venous 6 study. But there is evidence to show that they clinically are effective and safe as well. So start by having a chat with your TVNs and just say, look, why aren't we using this system? I've learned about it, and this would be fantastic on our wards. And what I will say is, feel free to ask other, you know, groups and people like myself for support if you need any support off air to help to, you know, push that in your practice or implement it in your practice. But they are available. I think you've just got to challenge why they're not in use and can we have them? Because if you haven't got the tools, you can't implement it, can you? So I totally get that.
And this comes down to confidence again. Too many healthcare professionals are nervous about challenging management, challenging procurement, challenging the system.
The one thing, Christine, that they'll say is when they initially look at the cost of the wrap, they'll go, oh my goodness, that's X amount, right? Don't ask me now, Ed, what the total cost is. But they might suddenly go, oh, that's a lot of money. But if you break that cost of that wrap system down that will last 6 months, and you break it down into how much a bandage system twice a week or even once a week would be, and time, the cost is minimal compared to that. And what is the cost to the patient when the wound's not healing? Massive.
Well, you've got the cost to the patient, but I can tell you exactly what the cost is. You're looking between £13,000 and £15,000 a year, non-healing leg ulcer. And we know that the majority of these should be healing in 12 weeks.
Yeah,
so,
exactly.
But again, it comes down to the confidence of the healthcare professional to be empowered enough to communicate the need and the solution for the patient's life, but also for the healthcare system's budget.
Yeah, and that's, you know, I've Christine, many times had to fight for what I call tools in my toolbox. And the one thing we've always had to fight about is regarding costs. But if you can show the potential cost savings, but the clinical effectiveness as well, that's what they'll listen to. But, you know, I would start with your TVNs and just say, you know, even if you just do a little pilot on the ward, you know, do a mini pilot alongside the TVNs about, well, let's see if we introduce this, what will it, like we did with those 15 patients. And that just helped us then to roll it out across the county.
Agreed. I better crack on with these questions.
Sorry, and you know I can talk for England.
We've only got about 8 minutes left, so I'll carry on. So from Debbie, good evening, Debbie. Thank you for your question. Is it acceptable to continue to support and visit patients who cannot fit hosiery themselves and have no family or carer?
Yes, totally. I don't know if that came across in my presentation. I apologise if it didn't. What I try to say is hosiery kits and wrap systems, your patients may not be able to self-care, but isn't it better if they're in that system for you as a clinician to go in? How much quicker is that to apply? You know, how much easier is it to apply? Do you need to be a registered nurse to apply it? You skill mix in your teams. Okay, if the patient can't apply it themselves but could roll the hosiery kit down and put an emollient on each day, which some of my patients do, and then, you know, pull the hosiery back up. It's not just for supportive self-care. These systems are going to help you dramatically to achieve your clinical outcomes, but save you time, save you valuable time. And also sometimes, you know, they're more acceptable for the patient to wear the compression then. Rather than, you know, so no, I use these for patients who are not self-caring. The patients will sleep in the hosiery like they would their bandaging. It's no different than sleeping in their bandaging. And then the nurses go in and support the replacement, skin hygiene, wound care, and replace the hosiery.
Brilliant, thank you. Next question, can patients do their own wound bed preparation and debridement at home?
Yes, totally. If we give them this, show them how to really cleanse a wound and the surrounding skin and the peri-wound skin. If you need debridement tools, you know, such as your monofilament pads, show them how to use it. I have children who debride their own wounds cleanse their own wounds because, one, they prefer it than me doing it or a paediatric nurse doing it. We have people of all ages. I have a 92-year-old gentleman who does his own wound care and his own skin care, and his own compression. So age is a number. Don't let that limit to you know, who you choose for these systems. It's irrelevant, you know. But yeah, it's yeah, definitely. We've got to, you know, it's no good giving the hosiery and not teaching the patient how to clean the wound effectively and to apply a dressing. That's part of the process, isn't it, of getting the wound to heal. So all of that, and there's some really good resources out there to show your patients how to cleanse the wound and how to put a simple dressing on. I mean, National Wound Care Strategy have lots of support information. Legs Matter campaign, fantastic campaign, have lots of support of how to change a dressing, how to cleanse a wound. Again, don't reinvent the wheel. There's some really good tools out there.
And age is a number, and I've been telling that to my mop of grey for the last few years. We have 3 questions left, Joy.
Right.
So next question, Maureen Johnson, thank you very much. Would you need to undertake a Doppler prior to RAPS?
Now, a RAPS system, see, this causes a lot of discussion sometimes. A RAPS system will give full therapeutic compression. Okay, so we're looking at your 40 millimeters of pressure. So ideally, yes. However, in some of our patients who cannot tolerate undertaking a Doppler, or the edema is extensive, that may make the reading unreliable, then I would say you've really got to have a very good patient medical history, very good assessment of the limb and perfusion and warmth and all the other factors, looking for any indicators of arterial disease. Or if you've got facility to do toe pressures, oxygen toe pressures, that's a good way as well, if you can't get an ABPI. What I'm trying to say there is, because it's full therapeutic compression, I would say yes. Now, somebody may disagree with me. Another TVM might say, well, no, actually, I have applied it without. But I think if you're how am I trying to put it? If you're a practice nurse or district nurse and you've got those advanced skills of assessing the limb, that's fine. But if you're new or not as experienced, then I would say, if you can't get a true ABPI and you want full therapeutic compression, seek the advice of a team lead or a professional lead or your TVN. And I'm always going to say that when it comes to applying compression.
Brilliant, thank you. Did patients move to self-care solutions from other systems easily on the audit?
Yes, and I think, you know what, there was, we had one patient who actually, so out of the 15, we had 16, and there was one patient who actually didn't want to do it, well, tried it and said, I don't like it. When we unpicked a little bit with that patient, nice gentleman, he actually liked the contact of the nurse. And he was honest, and he just said, as much as I can do it myself, and I'll hear off the practice nurse each week. But the majority, yes. And I'll tell you why. I mean, because I love listening to patients. I love getting patient feedback. And a lot of the feedback was around, we think community nursing patients, waiting for the district nurse because they love it. Even community nursing patients who are housebound don't want to sit waiting for the doorbell to ring. They want their independence, and this is what we were giving the patients as well. So I know it wasn't difficult, but as long as we spent that time showing them, educating them, and I think the main thing for the patients was that they knew somebody was at the end of a phone if they needed them as well. So they got that support in between. I think if we'd have just gone, there's your solution, off you go, etc., then it wouldn't have been as successful. It was successful because of the support that the nurse offered as well.
Brilliant. Last question, which is actually we've covered before, but I think it's really important. What evidence-based material is available to help select an appropriate individual for self-shared care?
What evidence is available?
What evidence-based materials available?
Well, the leg ulcer pathway is evidence-based around evidence-based for best venous leg ulcer management, best practice guidelines. It's evidence-based around the venous 4 study. It'll be further evidence-based if the venous 6 study shows anything. The pathway's been adapted as we've moved along with new evidence. So I know I'm involved, Leanne and I are involved with that pathway, but every time we've had new evidence come forward, we've updated that pathway. That pathway hasn't stayed. So the majority of pathways are based on the evidence that is available. So that evidence may be RCTs, that evidence may be less robust than an RCT, but it's evidence around clinical practice, but they will be backed on national guidance, international guidance and evidence around it. So I hopefully that's answered your question, but any pathways and any tools produced should be based around the clinical evidence that's available.
And as you said, people don't realise this, people can go to the Legs Matter site, they can go to the LNR site, they can go to the national strategy as well. And the links are all there.
Yeah. And the references and the evidence is there as well. So if you do need that additional confidence, where has the evidence come from? It will be supported by that, it will sit alongside those documents.
Joy, thank you. Genuinely, thank you. if you get a chance, watch this back. There's been incredible comments, some very kind comments as well. So
Thank you.
ladies and gentlemen. I'm aware that our hour is up and it's precious time. So the fact you choose to spend that with us means a great deal to me and the team. Joy, thank you. As always, really appreciate your time and commitment. Ladies and gentlemen, the certificate for attendance is now available. The link should be on the screen. Get that because it counts towards your revalidation portfolio. There's more information on our website, jcn.co.uk. Go there, have a look around. As Joy said earlier, get yourself over to the Squeeze In site. I've got it here, squeezein.life. It's a really cool site. It's very different to other stuff out there, completely driven by the patient. Go to the LNR site, but fill your boots. There's good content out there that will help you in the months and years ahead. That's the end of the event. Joy, thank you.
You're welcome.
Massive thank you for your support, not just over the last hour, but over the last few years. As always, to my team at the JCN and to Mold Digital, you guys are awesome. This comes across as quite professional, but actually it's you guys in the background who make it look so. And last but not least, to you guys out there, thank you for all your support over the last year. Thank you for giving us your time. It does mean a great, great deal. Have a very, very Merry Christmas, and we look forward to seeing you all in 2022. Good evening to you.